our next speaker is going to be Vaishali VASAVADA. We'll talk a little bit about the why I prefer a diffractive trifocal.
A very good morning to all, and thank you for the opportunity. And I'll try to make it in time. Dr. Shetty has really made my point much easier. Why I prefer diffractive trifocals. I do receive occasional research grant from Alcon Laboratories. I think the basic point we need to understand is that the newer generation trifocals have an excellent range of vision continuity, as well as they provide best-in-line spectacle independence, and the whole discussion about dysphotopsia and the negative effects is really going down drastically. So the chair time I find in my practice, and I'm sure a lot of you echo this, is going so much down. And the number of patients whom I can implant a trifocal are increasing. And this is what a recent meta-analysis also says, that 9 out of 10 patients do not need spectacles, and yet only 3 and 5% patients had any significant halos, glare, or starburst. So I think that's the real advantage we have with the newer diffractive trifocals across platforms, I would say. Let's look at real-life scenarios rather than going into a theory. This is a 71-year-old lady who wants to do almost everything like you and me would want to do, and I hate wearing these glasses just like she does. So she has come for a regular cataract surgery and has astigmatism. So we go ahead with a diffractive trifocal, and she has excellent continuity of vision and doesn't need computer for almost any activity, including driving. So this was a very standard scenario where we see that trifocals are of course a great option for spectacle freedom across distances. But let's move on to this really coveted situation of an active surgeon ophthalmologist who uses progressive glasses and has only about 10% use of multifocals in his own practice. But from whatever experience he has and he listens to his patients, he feels confident that I want to go ahead with a multifocal, a trifocal, and he also drives in the city at night apart from operating. So we were really on the back foot at this occasion, and we were trying to talk about all the negatives, all the flaws, but he feels very confident. And finally, having done a complete evaluation, of course, we did an astigmatism correction inbuilt as well. And after this trifocal toric binocularly, he is able to operate, he is able to drive, and in fact, he says that he would recommend it to any other surgeon. He does observe some halos at night, but as you see here, he says they are not really very bothersome. So it is now true that trifocals are also a great option for people who have a very precision-oriented and an active lifestyle also. Of course, it involves a discussion one-on-one about the pros and cons, but I think that category, the exclusion is becoming so much less now. Of course, the basic three things if I have to name, or 4 things. One is to evaluate the ocular surface and treat if necessary, because these aberrations, as you can see here, are a source of not only poor vision quality surface symptoms, but the first refracting surface of the eye is the tear film. So we better treat those because these will mar the results. The second, as we all understand, is to ensure a negligible residual refraction, both spherical as well as astigmatism. And so the use of modern devices, diagnostics, formulae, and like I said, astigmatism we cannot overemphasize. Looking at not only the magnitude but the regularity of Myers. So actually look at the raw data that is being pulled out from your machines. Just don't look at the printout of what it says. And having a good regular astigmatism, even if it is to the tune of 0.75 degree diopters, is treatable very predictably and really enhances results. And this is one paper we published way back in 2018 where that's when we started performing a posterior segment macula OCT for all our cataract patients before we counsel them for any IOL, leave alone a presbyopia correcting IOL. Now again, let's move on to other scenarios which are a little more diverse. Here is a 73-year-old myope, so always used to good near vision. Somebody did a monofocal IOL for her 3 years back, and she's not happy because she was never given the option of a multifocal lens at the time. So now she has come to us, can we do something? And this is data from her chart. This is the pseudophakic eye, as you can see. She has a spherical, cylindrical, and a presbyopic refractive error. And we are looking at this right eye now for refraction, for cataract surgery. So we again discussed with her that because it is going to be a trifocal only in one eye, we cannot promise that you will be rid of the glasses, but we can reduce your dependence drastically. And she really agreed, and she understood that she didn't want to compare the distance vision in both eyes. We told her two things. One, you might need a little pair of glasses. Second, please don't do this, especially comparing your distance vision in the monofocal and the trifocal eye. Now, post-operatively, she is 6/6 partial or 20/20 partial. Binocular is 6/9, and she is doing very well for near N6 partial. So I think it is also a good idea for unilateral or other eye monofocals. And the main point I wanted to bring about is patient needs to know all their options before you decide for them whether it's EDOF or this or that. Tell them, discuss with them. What happened to my, can I have my slides on the, yeah. So this is one case which is really, I think, the icing on the cake. A 42-year-old lawyer, criminal court lawyer, has had a familial nystagmus, comes with subcapsular cataracts. He understands his problems, what he has since birth, but he cannot wear glasses. And this is his, again, data post-operatively following bilateral toric trifocal implantation. 6/9, so 20/30, not 20/20, that's okay, he doesn't have that potential. But N/6 and all unaided, plano. So this is the video I wanted to show. I hope it plays here. Can you play the video for me? It was playing on your trial. I'm so sorry. So this is an eye with nystagmus and trifocal IOL, and here I want to show you that it's not just saying that I do this, I do that. This is the contrast sensitivity curve, which is just marginally at the lower level for his age matched. And this is also with glare. You see that dotted line on your right screen is with glare. So I think, and can you have the volume up, please? So I'm making him read the fine print of the Hindi newspaper, which is a really low contrast, and you see there are no lenses in his trial frame. And this is, of course, with his consent. So I think the whole message I wanted to drive, there are issues with any lens, including a trifocal, and the main issues we talk about today are two things: comorbidities and visual disturbances, and in country like ours, I think cost. But in most cases, with a good team that supports you, what is my strategy? Probably the emphasis is more on not whom to not to include or whom to exclude. It used to be a lot of discussion on who is a good patient. I think now the discussion is who is that little segment who is not a good patient for a trifocal. And the top reason for me, I think, finances apart, is a hesitant surgeon or an uninformed patient. Thank you.